Good afternoon. I'm Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update from the Department of Surgery. Today I'm very fortunate to be with Jenny Geurts, who's manager of our genetics counseling program here, and really a national expert in all aspects of genetic counseling. Jenny went to the University of Minnesota, where she then stayed for her master's degree in genetic counseling, and has worked with us now for a number of years, and has a particular interest in a disease which is very close to my heart, namely pancreatic cancer. But before we get to pancreas cancer, Jenny, maybe you could talk a little bit about really the exploding field of genetic counseling, genetic screening, and genetic testing. Maybe talk a little bit about all those terms and some basic general principles that I think all of the patients should know now that we're in this era of molecular medicine.
Yes, it certainly has been exploding, so that's a great phrase to use. So genetic counseling, so what we do in genetic counseling is we're really there to help translate complex genetic information that we may be getting from the laboratory and translating that for the patient and for the physician. And what does that mean for the treatment of the patient's condition or for their risk and future prevention of a certain disease? So within oncology, you can imagine there's lots of applications.
So if we define this a little bit to cancer, is it now true that almost every patient who has a solid tumor diagnosis, if we leave off the table for a minute the leukemias and a lot of the bone marrow diseases, if we take the common cancers such as breast, colon, pancreas, lung, should every patient have a careful personal and family history taken, and then when should a genetic counselor get involved, I guess would be my question.
Great question. So there's some guidelines out there about risk assessment and when it's appropriate to get a patient to genetic counseling and testing. In general, all patients should have a detailed family history taken. The questions we really want asked are, who in the family has had cancer? And we're interested in all different types of cancer. So even if the patient in front of us has breast cancer, we want to know if there was a family history of pancreas, colon, ovarian, because those cancers can be genetically linked. So that is important, knowing the different types of cancers, where the cancer started. The second question is about age of diagnosis. So unfortunately, we know cancer is common, but it's common after the age of 60. So if we see a young person with cancer, let's say someone in their 40s with pancreas cancer, that's not common. And so we suspect that may have more of a genetic or inherited component to it. So asking age of diagnosis is really important for family history as well. So there's certain red flags that a doctor will look for in that family history and then refer to genetics when they're concerned about a hereditary risk.
How accessible are genetic counselors? In other words, if we assume that certainly at a large medical center like this one, there obviously are a number of genetic counselors, but in many places there probably are not. And for those patients who see a doctor where a genetic counselor is not readily available, what can you tell the patients who are watching this video? How can you advise them as to when they should say, you know, I really need to perhaps be referred to a center where I can have a conversation with a genetic counselor, either on the phone or in person?
Yes, access has been a challenge for genetics because, as we mentioned, the field is exploding. And so right now we're working to train enough genetic counselors to meet the demand. But right now there is so much demand, we have to get innovative with our service models. So one of the things that we're going to be piloting here is actually a virtual genetic counseling visit where we're able to, through the television and through our computers, talk with a patient about genetics, so we don't have to be physically at that community site. So we are trying to get genetic counseling out to the community. There's also services that provide telegenetics as well. But really, I think genetic counselors are accessible in most major cities. And in the state of Wisconsin, we've done a pretty good job of scattering genetic services across the state. Here on this campus, we have about 20 genetic counselors, which represents about a third of the genetic counselors that are practicing in the state. So we have definitely a good dense population of genetic counselors here in the metro area. But I would say really talking with the doctor, trying to find a referral, and then just making that appointment. Absolutely.
Sure. So if we take the two extremes, so if I am adopted, for example, then obviously I probably would have little information to provide you. However, if we take the other extreme, where there are perhaps 10 members of my extended family with cancer, then that clearly would attract some attention. What about the gray zone in between? And what if a patient, really loves their doctor, but genetics and genetic counseling is really not their area of knowledge base? When should the patient say, I really need to talk to a genetic counselor? Are there any guidelines you can provide?
Yes, so absolutely. So we're lucky enough to have the National Comprehensive Cancer Network publish guidelines around referral to genetic counseling. Every once in a while, we are met with some opposition from physicians who maybe aren't familiar with genetic counseling, that practice in more rural settings, that haven't had experience with genetic counseling. And we always tell patients we're open to self-referral too. If patients ever want to call and talk over the phone, I'm happy to do that. If they would like to come in based on a self-referral, we're happy to do that as well. And so yes, these guidelines are out there, and actually even beyond the National Comprehensive Cancer.
So you're saying that they can just put in Google the NCCN, and they'll be able to see exactly if they have a breast cancer diagnosis or a colon cancer or a pancreas cancer diagnosis through NCCN. They can look that up and say, okay, if these family members are present within your family, you need genetic counseling.
Absolutely. NCCN is one of the great places to go. Also, the U.S. Preventative Task Force has also set aside guidelines for when genetic counseling and testing should be offered. So the American Cancer Society, a lot of these large groups have tackled this exact issue and made it very clear when someone should get in and get more education around the genetic testing.
Great. So genetic counseling is your discussion with the patient and their family and construction of a pedigree and risk assessment. And then testing is the blood draw, correct?
Correct. Thank you for clarifying, because a lot of people get those two mixed up and think it's all one thing. When patients come in for a genetic consult, they're really coming in for information, for education, making sure they know what our genetic testing can and cannot do, making sure they know what they're being tested for, and having an appreciation for how the results may impact their care and the care of their family. So after that conversation, that informed consent, if the patient decides, yes, this is right for me right now at this point in my life or my diagnosis, then we can do the genetic testing right in that same visit, which is typically a blood draw. If the patient decides, wait a minute, I need more time to think about this, or I want to talk to family, get some feedback, then they can come back at any point later down the road to have the genetic testing if they choose.
Okay. And the downside of genetic testing, other than in those cases where their insurance won't cover it, there's obviously a financial implication. So there's cost. But what other potential concerns would patients have about the blood draw, about the testing part of it?
I would say historically the main concern has been cost. However, genetic testing technologies have been getting much, much better, and it's driven down the cost of testing considerably. Where 5 years ago, genetic testing for the breast cancer genes was over $4,000, and there was a patent on the gene. We could only do it at one lab in the nation. Nowadays, the U.S. Supreme Court decided that patent was no longer valid, so you can't patent genes anymore, which also increased other laboratories being able to offer the testing, drove down the cost. And so now, on average, our genetic testing costs are less than $500, and we're getting hundreds of genes that we're able to test for a much more reasonable cost than we were previously. So testing cost is becoming less of an issue. The other caution that people take with genetic testing is they're concerned about discrimination. So we have a good conversation about what state and federal laws exist for protection against discrimination in the workplace or based on your health insurance. And so patients understand what the implications of testing are from an insurability perspective.
So in other words, if they were found to have a germline mutation in all of their DNA, that was associated with an increased risk of cancer or something else bad happening to them, then there could be discrimination with respect to their ability to get insurance. Is that
correct?
Is that right?
Theoretically. So that's where
and that could then have implications for their job,
right,
for being able to be hired.
Exactly. And so that's why these state and federal laws have been enacted to protect people from that, because we really are trying to move to a proactive, preventative healthcare system where what we tell people is everyone's got something genetic. Something runs in everyone's family, whether it's heart disease or cancer, diabetes. If we know what we're at risk for, we can tackle it early, we could possibly prevent it, or with early detection have a better outcome. In the end, that's going to cost the insurance company less money to pay for preventative things rather than treatment. So people are coming around to it, insurance companies are coming around to it, and that's one of the reasons actually insurance coverage is quite good for genetic testing when patients meet criteria. Because the insurance company understands it's a lot cheaper for them to prevent a cancer than it is to pay for a cancer.
Yeah. Great. Well, maybe you can talk a few minutes now on the program that you and Dr. Susan Tsai have developed for screening high-risk individuals for pancreas cancer, and maybe in the context of a general review of genetic counseling for pancreatic cancer, because a number of people listening to this video, patients and patients' families, and potentially those with family members with pancreas cancer, know that you're an expert in this area, along with Dr. Tsai. And the clinic that you've developed is really unique within the United States. And a few words about the disease, what you're looking for, and how you're taking care of those families.
Yes, thank you for that opportunity, because it is a clinic that I'm really proud of, and I think we're doing some really great work for patients. So the clinic you're referring to is the Greater Midwest Pancreas Screening Clinic, our GPS clinic for short, as we call it. And we hold that clinic once a month, and we see patients from all over the Midwest, all over the nation really, who want to do something about their risk for pancreatic cancer. And there's three components to our program. The first is the genetic risk assessment. So what is high risk for pancreas cancer? Actually, the majority of people that develop pancreas cancer, it's a sporadic process. We think maybe it's just chance or something in the environment or a personal risk factor. Only about 15% or so is due to hereditary factors that are genetic that have been passed down either through the mother's side or the father's side. So our clinic is really focused on those families that have the hereditary factors. And so that genetic assessment, what we're doing is the detailed family history, the pedigree. We're also offering genetic testing and then trying to identify the risk for pancreas cancer and potentially other cancers through that genetic assessment. Once we've determined that that family is at an increased risk for pancreas cancer, we want to do something about it.
Sure.
So the second piece to that is a wellness component. So we make sure we have a good conversation about smoking cessation. If anyone in the family is smoking, that's a major risk factor for pancreas cancer. And if you have a genetic mutation and you're smoking on top of it, it's like adding fuel to a fire. So we want to make sure people are doing everything they can to prevent pancreas cancer. We also have a dietitian that talks about nutrition and things that can be done to help keep a healthy body, staying physically active. And then the third portion of our program, the major portion of it, is the screening component. So unfortunately, we can't prevent pancreas cancer like we could prevent ovarian cancer, or we just remove the ovaries after a woman's gone through menopause and they go on living a normal life, and we prevent ovarian cancer. With pancreas cancer, as you know, it's a vital organ. You need it. And so we can't preventatively remove people's pancreas.
We certainly don't want to.
We don't want to, and people have asked us to, and we have to say no, because you really do need it. So the idea is if we could practice early detection. We knew here that we had a really good imaging, some of the best imaging in the nation, if not the world here. And imaging is key in the pancreas, as you can appreciate. If we can find a very early stage cancer, even when something's precancerous, as a little ditzel on an MRI, and address it at that point, before there's even a hint of symptoms, that's what we would want to offer these families.
Sure.
Because these families often have experienced what happens in a typical diagnosis of pancreas cancer. Months and months of symptoms that are non-specific.
Oftentimes a delay.
delay, misdiagnosis, and it's not before the cancer is quite advanced that all the pieces of the puzzle come together and the person's given a diagnosis of pancreas cancer. So we do not want that for any other family members. So hopefully with our advanced imaging techniques and MRI, we're able to detect pancreas cancer as early as possible, even in a precancerous state, and then address it at the point where we have an opportunity to cure the disease.
Absolutely. And certainly the peace of mind that comes with knowing that they've talked to an expert like you in the field. They know whether their family is at increased risk or not based on our current state of knowledge of the science, and then a screening program that really takes advantage of the highest level of technology. So, I mean, certainly for my patients and my families that have accessed your clinic, it's just a tremendously powerful tool to make them feel at ease that at least, even though they may be at increased risk, everything possible is being done to abrogate that risk to some degree.
And that's exactly our conversation. It's empowering for the patients to know, I'm not just going to sit back and be a victim of what's happened in my family history for possibly generations. This is the generation where we can change things and moving forward ensure that the same fate doesn't happen for them.
Sure. Well, maybe I'll give you the last word now on, we will provide all of the contact information for Jenny and the GPS program, but maybe the last word on where genetic counseling has come from and where you think it will be, say, in the next 5-7 years.
Yes, that's interesting to think about because even 5 years ago, I couldn't have imagined how far we are now. We've come a long way with the technology in the last 5 years. And so 5 years from now, my hope would be that we would even further understand the genetics of pancreas cancer. We have several families that certainly appear hereditary, and the genetic testing is uninformative. We aren't able to pinpoint the gene in that family. I want to find answers for those families. Find the culprit gene that's running in the family.
Sure.
And the second piece to that, I think really where the newer technology is heading is in the area of liquid biopsy and early detection. Right now, MRI imaging we feel is a very good defense against screening for pancreas cancer. But ideally, we'd be able to develop some simpler blood test, like a liquid biopsy, that we could offer everyone in the general population, something
Sure.
they could even get at their primary care doctor, where there'd be a genomic signature there that would tell somebody very early on, you're at risk for developing pancreas cancer. Not only the hereditary type, but also the sporadic type, which is the majority of pancreas cancers. So I see that happening in the future for genetics and pancreas cancer and genetic counseling. And the role of the genetic counselor is making sure that education is provided to the patient so they understand what they're being tested for, what the limitations of the test are, and to the providers on what new technologies are out there.
Yeah, great. Well, hey, thank you so much. This has been
welcome.
fantastic. And I would remind everyone watching the video that Jenny's contact information and that of the genetics program here at the Medical College of Wisconsin, as well as the GPS clinic, will appear at the end of this video. So thanks again.
Thank you for the opportunity.